And then like something like flew onto their table, and I was like, we're good? Okay guys, let's get started. Can everyone please come in close, because I have really bad conventionalitis and I am so sick and my voice is going to disappear. So like really come in. I'm also going to be showing stuff on a patient in the middle here, so gather please. So 3 things to start the tutorial. First, this is my approach to OSCEs. It will not be any of your approaches. What you will do and what you should do is watch all of these tutorials, take the good bits from every person you see and make your own unique approach. So please don't take everything that I say as gospel. The second, when I was in second year, I did not have my shit together as much as I appear to today. I did not know 90% of the stuff that I know now, and I still passed. So the reason that I'm here and the reason that each of us are here is because we want you guys to be better than we were, but you also don't need to be at the same level as a 3rd, 4th, 5th or 6th year. So don't panic. The third, group study is the best study, not just for OSCEs, but for absolutely everything. The amount of study I did in second year was about 25% that I did in first year, and my grades were better. And that's because I did group study. So in any exam, any situation, please group study as much as you can. It will also set you up really well for 5th and 6th year physicians exams, everything ahead. That's my words of wisdom for the day. Approaching the OSCE. So I'm not going to talk through all this, but this is just to highlight. There are 8 things that you're marked on, and 5 of them are just about the history. So if you can competently talk to a person without saying something grossly offensive, you will pass. So don't panic. History. So I remember when I was doing these tutes, we would always request that people actually demonstrate how to do something instead of just talking through. First you do the history of presenting a complaint, and then you do the past medical history, and then you do the family history, because everyone's like, I know how to do it. We know the general order. So I'm just going to go through some quick notes of each section, and I'm going to demonstrate / role play some sections that are really high yield or are really commonly done poorly. And also your approach doesn't have to be standardized. It should be personalized, not just to how you do things as a person, but to the patient in front of you. Wipe. So sometimes when you walk into an exam, you just kind of turn into a messy puddle and you forget how to do things like breathe and walk and not wet yourself in front of a patient. So having really basic acronyms actually helps you to not make any of these horrific mistakes, because they're things you don't practice because they're so easy. So wipe, I still use now when I walk into a hospital. I go, wash hands, introduce, permission, position, exposure. Washing your hands is something that's really awkward in OSCEs. I remember like one of the stations, I washed my hands too much and then my hands were still soapy and wet, and I tried to pick up the paper and I got water all over the paper and it was a mess. And then another station, the hand sanitizer was outside of the station. So I walked in to talk to the patient and I wanted to touch the patient. So I went outside and sanitized my hands again and came back in. And then I finished and I went outside and sanitized my hands again and came back in. So like you don't have to be that thingy about hand washing. You just have to show that you're thinking of it. So if you come into that kind of awkward situation, just mime it to show. Or UNSW MedSoc has some handy belt loop sanitizer that you can get from us. But either way, don't like panic about being that stringent about perfectly wiping your hands every time. They don't need to know that you know how to like do the 90-second hand wash. They need to know that you have to do it. Get permission to do absolutely everything. This is part of the marking criteria that they're marking you against. The whole first marking criteria, by just like introducing yourself and saying hi to the patient, you've ticked off one criteria, so don't forget to do that. And in positioning the patient, everyone thinks about the way they're positioning the patient, but you also need to make sure that you're positioned in a way that's comfortable for both you and them, so you're not awkwardly kind of like standing over them while they're laying in the bed and you're taking a history kind of thing. So make sure you're both comfortable in the position. And exposure is always last. Leave it until the last minute that you have to do it. So having some standard phrases, everyone has them, they're really handy. So everyone says, hi, my name's Dana, I'm a second year medical student from UNSW. They don't care that you're from UNSW, no one on the wards does. You can drop that bit off and that saves you some time and energy. Also, every single person they're seeing today is a second year medical student. They don't really care about that either. Hi, my name's Dana, how are you today? Easy. And that also ticks off a criteria in the marking sheet. One of the marking criteria is outlining your expectations of the time. So saying what you're going to do and what it's going to involve, and I'll role play that in a moment. And always ask permission. Consent is really important, so don't forget to say, is that okay with you at the end of it? And then when you're kind of segueing into the history, you'll say, okay, so what's concerning you today? Here are some other things that students might say, and you can say whatever you're most comfortable with, but what's brought you here today is one that everyone says, and the patient always says ambulance, and you're always just like, internal groan. Or you say, what's concerning you? And they're like, my grandson didn't make the baseball team and I'm really worried about it. Or they say, what's wrong with you? And they're like, what do you mean? What's wrong with you? Why are you here? It's like, because I'm sick. How can I help you? And they're like, oh, my pillow is actually really uncomfortable. Can you help me get a new pillow? Or what are your health concerns? And they're like, oh, 30 years ago, I had a really bad stomachache and I think the doctors gave me some bad medication. So I really like what's concerning you today because it really like brings them into what is this about? It's just my favorite line. You don't have to use it, but in using these, beware. There's no perfect line, but there's whatever you feel most comfortable with and whatever is most likely to get a good response from the patient. Okay, let's role play the introduction. Can I have a volunteer patient to introduce myself to?
Sure.
Hey, come sit. Another pro tip, write down the patient's name because you'll get to the end to summarize and you'll realize you've forgotten their name. Okay. Hi, how are you today?
Hi, I'm good, thanks.
My name's Dana. What's your name?
My name's Kieran.
Kieran, it's nice to meet you. Kieran, I'm a medical student. I've been asked today to perform a cardiovascular history and examination on you.
Okay.
So what that's going to involve is I'm going to be asking some questions about what's concerning you right now and also your past medical history and your home life. And then we're going to have a bit of an examination, which is going to involve me asking you to remove your shirt. And then I'm going to have a look, a feel, and a listen to your arms, your face, and your chest. Is that all okay with you?
Yep, that's fine.
Okay. So what's concerning you today? That's okay. So it's concise. You've signposted exactly what you're going to do. Make sure when you're getting consent that you're going to tell them it's going to involve removing their shirt. I'm going to be touching your arms. I'm going to be looking at your face. I'm going to be touching and listening to your chest. So they kind of know what to expect from the outset. And with the next bit, I got a lot of shade from my housemates for this slide. I thought it was funky formatting. I don't know what you guys think. It's fun. So, history of presenting complaint. This is something you guys should go through at home. You know the common symptoms. You know how to do your Socrates and what to ask about. Chest pain, palpitations, dyspnea, syncope, peripheral edema. Always ask about constitutional symptoms in every single exam ever. And you can know the extras, but honestly, I didn't really understand orthopnea and PND properly until third year, so you can definitely get by without it. Just know your core 5 and you'll be fine. So Socrates. Does anyone know the quote, when you hear hoofbeats, think horses? Is that familiar to anyone? Does anyone know where it's from? No. So officially, it's Dr. Theodore Woodward in the 1940s, but most importantly, Meredith Grey says it. But it's very true, and you should keep it in mind throughout all of your OSCEs, not necessarily in hospitals, because the approach sometimes is a bit different. But like if I say central crushing chest pain, sudden onset, radiating to my left arm and jaw, no alleviating factors, what have I got? Heart attack, yes. If I say I've got like a tight chest when I exercise, but when I rest it gets better, or when I use my spray under my tongue. Yep, stable angina. And when I sometimes randomly get chest pain, it's that tightness and heaviness. It resolves itself eventually. Unstable angina. Those are the 3 things that you're most likely to get. So if you know your horses, you're likely to get 80 to 90%. Even if you don't know them and what they are, you're still going to get the marks for going through the correct processes. But if you want to look really special, you need to rule out some of the really serious zebras, and it's good to know them for future practice, but don't stress yourself with them. But pain on inspiration and expiration, what are you thinking? Yep, pleuritic chest pain, something respiratory. Burning pain present at rest, non-exertional, not related to respiration. Yep, gourd. Positional pain, worse at rest, prolonged, localized, chest wall tenderness. It's just a strained muscle. Or instant severe tearing pain. Yes. You know more than me. You sure you don't want to teach? So it's good to know these things, but you don't need to know these things. But the really serious ones, it's good to know to rule out. So, but you're not going to get them in a phase 1 OSCE. Past medical history. Everyone has their own way of doing this again, but you start specific and then you kind of go broad and then you narrow down again. So you say, do you have any history of heart problems? Because that's what you're worried about today. And then you want to get their general medical history. People generally aren't forthcoming with this, and it can be quite difficult to get things in an ordered way. So the way that I like to do it is, first I say, do you see your doctor regularly for anything? And then, have you ever been admitted to hospital? And then, have you ever had any surgeries? If something doesn't fit into those 3 categories, it's probably not worth worrying about. And if they don't remember anything in those 3 categories, it's the patient actor's fault, not yours, because you've asked everything you need to ask. But then you want to show that you're really thinking about the differentials and you're thinking about cardiac exam. So you can ask a few specific risk factors, and markers love risk factors. So in the cardiac exam, you ask cholesterol, blood pressure, diabetes, heart disease, stroke. You don't have to ask all of those things. You can just ask 2 or 3 of them and they'll be impressed. And then and then medications and allergies. Some people like to ask it in past medical history. Some people like to ask it at the very start. Some people ask it in social history. Kind of do whatever works best for you, however is flowing with the patient, and however works best for the specific condition that you're looking at. I always do it with past medical history, because when they say, I have diabetes, do you take any medications for that? I have hypertension, do you ever take any medications for that? Another thing to note is to remember not to use hypertension like I just did. If you're talking to a patient, it's high blood pressure. It's high cholesterol, it's not hyperlipidemia. So make sure you use layman's terms with the patient and use your medical terminology when you're summarizing at the end. This is a little extra thing, not necessarily needed at phase 1 level, but for heart disease, it's really good to ask smoking, exercise, and diet early on in the exam, just in case you're running out of time, and to show that you're really focusing on the differential. So I would ask that with past medical history. And then family history, again, very general approach. I will send you these slides afterwards, by the way, guys. I know it's infuriating that everyone says that. It's like, I don't have time afterwards to review the slides. I just want to get my notes done now. This stuff isn't high yield, and you're going to go over it again and again with the next 3, 4, 5, 6, 7 tutorials you have. So family history. Again, start general. Anyone have a history of heart problems? Get more general. Anyone have a history of anything? And then specific risk factors. Cholesterol, blood pressure, heart disease, stroke. And I wouldn't spend too much time on family history, particularly at a phase 1 level. It's not very high yield, as long as you have an opportunity to show that you're thinking about it. So you've shown that you're thinking about heart disease, you've shown that you want an overall picture, and you've shown that you have some specific risk factors. As long as you've demonstrated your critical thinking, the marker doesn't need anything else. And then social history. So this is a really unusual approach. This is actually what you get taught, I believe, in BGD-B for adolescent mental health, and I use it with every single patient I've seen since, because it is the perfect way to structure a psychosocial history. It goes through absolutely everything in a really good order, because it starts kind of like light and casual, and then you get into the really like kind of dark stuff, and it makes sure that you tick off everything in your head. So I would highly recommend using this at every chance that you get. Practice it over and over again. I would like to demonstrate it. Is there someone else that would like me to have the same again? No? No one would like me to take that psychosocial history? You can make stuff up. Yeah, come on. Okay, so next we're going to have a bit of a talk about your home life and your life outside of your work and study. And this is just to get a bit of a picture of how that impacts on your health and also how that will impact on your management going forward. Yeah. So can you just tell me a bit about your home life, where you live and who you live with?
So I'm right now living with my parents at home. It's about in Liverpool.
Okay, fantastic. And do you study?
Yeah, I'm currently a 4th year uni student.
Okay, sounds pretty full on, must take a lot of your time up.
Yeah.
And do you work outside of study?
Yeah, I do a bit of work like casual at the cashier in Target.
Okay, so just in retail?
Nothing serious.
Okay, and so outside of work and study, how do you like to spend your time?
That's a good question.
Do you play any sports?
I sometimes go out for a run occasionally, but that's very sparse.
Okay.
Usually like once a week. But apart from that, it's just watching TV at home and stuff.
Okay, and do you enjoy spending time with friends at all?
Yeah, sometimes I go out. I don't really go out that much though. I'm more
Okay.
of a alone kind of person.
Okay. And do you drink at all?
No.
No?
No.
And this is just a question I have to ask everyone. Have you ever done any illicit substances?
No.
And have you ever taken any prescription medication for non-prescription reasons?
No, not for non-prescription reasons.
Okay. And so you said that you go for a run occasionally. How many times a week do you exercise for 30 minutes or more?
Oh, probably once.
Once a week?
Yeah.
Okay. And can you tell me a bit about your diet?
I'd say it's pretty good. Like, I try to get a decent amount of vegetables and stuff in. I could eat a bit more fruit, I feel, but apart from that, I think it's all right.
Okay, so how many times a day do you eat fresh fruit or vegetables?
Vegetables once a day. Fruit very rarely, maybe like once a week or something.
Okay. And how many times a week do you eat takeaway food?
I usually, like I said, I usually don't go out that much, so I usually don't eat takeaway.
Okay, fantastic. And I won't ask you about sex and sexuality in front of the whole class, just to spare you that pain. Let's move on.
Okay.
And that's not relevant to every exam. In my Phase 1 OSCE, I had like a 62-year-old woman who came in with leg pain, and I asked her about whether she was sexually active, and it was so awkward. It's not relevant, don't ask. But if you have someone who's trying to get pregnant, practice asking a lot about sexual history, sexuality, ask what kind of sex they're having, because there's always going to be that one patient that's like, I just can't get pregnant, and then you realize that they're like still using contraception and they don't understand how it works. They're like, no, condoms stop you from getting STIs, not from getting pregnant. That's how you have the pill. Probably not going to be too much of a problem at a Phase 1 level. I don't think they'll chuck you in that deep end, but I did have a patient who was trying to get pregnant, just had to touch on the history. You don't have to go really in depth, but make sure you do ask if it's relevant. But you can see how using that approach, you kind of start broad. Tell me about your home life. Tell me about where you live. Tell me about your education, your employment. Tell me about your friend group. What do you do? Do you drink alcohol with them? Do you smoke? Do you do drugs? I forgot smoking. And then kind of narrow down to some of the deeper issues if it's relevant. Practice doing this over and over and over again. Like, I would say once a week, but honestly, I did it twice before OSCEs, but you guys can do better. Once a week, just sit down with a friend and like take their social history, because it's something that's really hard to do. If anyone ever wants to take my social history, I'm just hanging around Wallisworth a lot of the time. Approach me, take my history. Like literally just come and sit next to me like, hi Dana, can I take your history right now? And I'm like, yeah, sure, why not?
What about suicide and depression? Would you just screen for that with any teenage patients or what?
So I didn't get any teenage patients in my OSCEs. I'd be surprised if they chucked you in the deep end like that. But I would kind of start broad with that as well and say, look, I'm going to ask some difficult questions. If at any point you feel uncomfortable, let me know and we can stop. Have you ever had any issues with your mental health? And if they say no, I would probably just stop there. But if they say yes, can you tell me about that? And they might say, oh, I've had depression, I'm on antidepressants, I've had really bad anxiety. And then you might say, have you ever had any thoughts of self-harm? If they say yes to that, have you ever had any thoughts of suicide? If they say yes to that, then you say, have you ever had a plan? Have you ever had an attempt? I highly, highly, highly doubt they'll get into that far with you in Phase 1. That would be very rough. Yeah. But just general approach with everything social and psychosocial, start broad and then narrow down. General history tips. Go where the discussion takes you and bring it back to the structure gently. Does anyone meditate? Yes. Every registrar so far has told me, you need to meditate, it'll change your life. I wish I started meditating in medical school, and I wish I do too, but it's hard to get into the habit of. But you should definitely try it and keep trying. And it's a great metaphor for how your history should work. So it should just kind of be flowing along the way it goes. And then something will take you off into a tangent and you don't jerk it back to the stream of where you were going. You kind of gently bring it back. It's just kind of a good metaphor. One Giant Mind is a great app. You should definitely try it. At least do it once or twice before OSCEs, if nothing else than to stop you feeling so stressed. But also it's kind of a great way to approach OSCEs in a really zen way. And then when you're sitting in the waiting room before going into your OSCE and everyone's nervous energy and you're freaking out, just closing your eyes and being able to relax every muscle in your body sequentially will get you in a really good headspace, and you'll approach your OSCEs much, much better than you would otherwise. remember the whole thing that Silas is obsessed with, but it's actually kind of genius, of open-ended questions to close-ended questions? There are people in 3rd and 5th year that still haven't got this right. It's hard to remember to do so many different things at once. You're trying to remember to do the checklist and go with the flow and ask open and closed-ended questions, and all of those things conflict with each other, and sometimes it just doesn't work. But just kind of not holding yourself to those structures, but remembering them in the back of your head. And it will make your history so much easier, because if you ask a heap of closed-ended questions, then you're just going to take up so much time. Whereas you ask an open-ended question, they'll tell you the 4 bits of information you need to know, and you move on. So try to do it, but don't force yourself to do it if it doesn't flow. Layman's terms with the patient, medical terms in the summary. Signposting as you go is a really good practice that I'd highly recommend. So the same way at the start that you said, I'm going to ask a bit about what's concerning you today, and then we're going to have a discussion about your past medical and family history, and then we'll discuss a bit more about your home life and how your health affects you. And then as you go, you say, okay, now we're going to talk a little bit more about your past medical history. Now we're going to talk a bit more about your family history. Now I'm going to ask you some more questions about your home life. So it really helps to give structure and keep the patient with you where it's going. I've seen someone sit in with like a consult, it was an ophthalm consult with like a 70-something-year-old lady, and they said, okay, so do you drink alcohol? Have you ever done illicit drugs? And she was just so taken aback. She was like, whoa, where did this come from? Signposting is really valuable in those situations. And above all, don't panic. As you saw at the start, 5 of your 8 marks come from taking history. If you can take a history well, and I'm assuming all of you can because you could do your med school interview and that is the level of competency that is needed to do a basic history, you will be fine. So just focus on the positives. Each station is different, clean slate. As hard as it is to not obsess about, oh my God, I can't believe I completely forgot to ask about smoking in the last station, try and put it out of your mind and move on. All right, exam. So we spend so long practicing every single exam a million times over, memorizing every single peripheral sign, and it's worth 2 out of 9 marks for the entire station. So it's not particularly high yield. Yes, you need to put that level of effort in to get those 2 marks, but don't kick yourself too much if you miss something small. It's not going to have a huge impact overall. Everyone knows the standard approach. You observe around the room, you observe the patient, peripheral stigmata, exposure and position, inspection, palpation, auscultation. So look, feel, move is generally the approach in everything. I might demonstrate an exam on someone. Michael, would you like to be my patient?
Yes.
And Andrew is my examiner. So I'm going to walk in as if I'm doing a examination only station, which you don't get at phase 1, but you do get at phase 2. So, hi, how are you? My name's Dana.
Nice to meet you, Dana.
Would you like me to begin?
Yes.
Thank you. So I'm just going to, so hi, Michael, is it?
Yeah.
My name's Dana. I've been asked to do a cardiac examination on you today, which is going to involve me asking you to remove your shirt, and then I'm going to have a bit of a look and a feel of your arms, face, and chest. Is that okay with you? Yeah. I'm also going to be reporting back to my examiner as I go, but if you have any questions, please feel free to jump in at any time.
Okay, sure.
Okay. So first I'm just looking around the room. I'm looking for any ancillary medical devices, in particular any ECG leads, oxygen masks or mobility aids, and none are noted. The whole idea that Vinny's hides walking frames under the bed is like a complete lie. Don't worry about that, please. They're not mean to you. They all want you to pass. So next I'm having a look at the patient. And the patient seems generally comfortable at rest, no signs of respiratory distress, no signs of pain, and no visible weight loss or pallor. Okay, so can I just have a look at your hands? So I could probably list like 16 hand signs. You need to know like 4. It's not high yield. What you're really looking for is on the chest, so don't spend too much time on the hands and arms. It's not worth it. So just having a look for any signs of palmar crease pallor. There's no Janeway or Osler's, no signs of xanthoma, no signs of peripheral cyanosis, no tar staining, and capillary refill bilaterally is less than 2 seconds. Just having a feel of the pulse. Pulse is regular and strong bilaterally. And examiner, can I please have the pulse, the respiratory rate, and the blood pressure?
Yes.
Okay, thank you. So I'm just going to have a bit of a look at your face now. So there doesn't seem to be any signs of malar flush. Can I get you to have a look up at the ceiling? And I'm just going to gently pull your eyelids down. No signs of conjunctival pallor or xanthelasmas. I think I got those the right way around. And can I ask you to open your mouth? pen torch. And put your tongue up to the roof of your mouth. No central cyanosis and dentition is good. Thank you. So now ideally I would like to have the patient lie at 45 degrees on the bed and ask them to remove their shirt, and I would assist them if they needed doing so. For the sake of this examination and patient comfort, I'm not going to do that at this point. So just having a look at the neck. Can I ask you to look over here, please? Thank you. So I'm unable to see the double flicker of the JVP, and on occlusion there's no JVP filling. However, if I did see the JVP, I would measure the sternal height for elevation. And just looking straight ahead and relaxing, I'm just going to have a feel of your neck. Might be a bit uncomfortable, I'm sorry. Okay, carotid pulse is strong bilaterally, and there's no signs of tracheal deviation. I'm just going to have a bit of a listen to your neck now. No signs of stenosis in either of the carotids. Okay, now the patient has their shirt removed, so we look and then we feel and then we move. So observing the chest, there's no signs of scarring, no chest wall deformities or no other trophic changes of concern. Having a feel for thrills, heaves, and the mitral pulse, apex beat. And then listening. So everyone has their own way of doing this. I would go the bell first in the apex, and then you flip around to the diaphragm and do the other 4. So 1, 2, 3, 4, and then ask them to lie on their left side laterally and go back to the apex with diaphragm and bell, and then lean forward and listen in both the aortic and pulmonary areas with the diaphragm. Now, are there anything else you'd ask the patient to do while they were leaning forwards? Full inspiration, full expiration. So that exacerbates the various valves. I don't know off the top of my head which one's which. I'm pretty sure it's that side is full expiration, that side is full inspiration, but I don't remember specifically which ones. And you don't need to. The examiner is just going to be impressed that you know that. And then thank you very much for your time today. I'm going to ask you to put your shirt back on. Do you need any assistance with that? No? Thank you very much for your time. And hand hygiene again, you can just mime it. And I'm going to report back to my examiner now. Turn back to the examiner. So I have a way that I've been doing it for the last 3 years. So I work from the top, feeling down, and then listening from the bottom up, and then back down to the bottom again. That's just the process that I've developed. So everyone has their own way of doing it, as long as you have your own way. Yeah.
So when you say you go, so you feel down,
yep.
You listen up,
yep.
And you listen down again.
No, you only have to listen down at the bottom.
Right.
So you.
So what's the thing with pointing back?
So you start by feeling. So you're feeling for thrills and heaves. So you're feeling here, here, and here. So basically all the sides of the heart around, if you've got a female patient, around the breast. If you've got a male patient, doesn't matter. And then you're listening. So you listen to the apex beat, the tricuspid beat, the aortic and the pulmonary, aortic and pulmonary. And then you need to re-listen to the apex beat in the dynamic maneuvers, and then lean forward and listen again at the top.
Okay.
Yep.
Why don't we listen again at the top?
So if they're leaning forward at the top, you will better be able to hear the aortic and pulmonary regions, and if there are abnormalities there, you'll also want to listen to the carotids, because the abnormalities can radiate to the carotids. Yeah. Any other questions about the examination? I know I just smashed through it. I've got it on the slides, and we'll go through it again.
Sorry. For the reporting back as you go.
Yes.
Do you wait until the very end, or do you just report as you go?
Completely up to you. I find it so much easier to report as I go. I hate waiting until the end. There was a myth spread that you will be not allowed to report back as you go. I don't think that's true. If you do have it, practice both ways so you're comfortable with both ways, but you'll always have one that you're more comfortable with. It'll probably be reporting as you go, because it's also just a way of signposting in your head what you're doing. And even if they don't let you report back as you go, you can report back to the patient as you go. So I'm just going to have a listen to your heart now. Okay, I'm going to have a feel now. And now I'm just going to ask you to lie on your side, so you're still signposting for yourself and the patient what's going on. Another thing to remember is when you're reporting back to the assessor, don't cut the patient out of the picture. So make sure they still feel comfortable, you're still telling them what you're doing. Any other questions? Okay, we'll go through it on the slides. How much time have we got left? Oh, plenty. Cool. Cool. So general observation, the room and then the patient. You don't need to remember a million different ancillary devices that are different for each person. If you on the spot forget, you can just say ancillary medical devices. That covers all bases. For pretty much every patient, you just want to say that they're alert and comfortable. You can talk about specific things like no signs of jaundice, no signs of wasting, no signs of pallor, but as long as they're alert, comfortable and don't have any signs of respiratory distress, you're okay to go on with the exam. Peripheral signs, again, there are so many. It's good to know what they mean. You don't have to know what they mean. I certainly didn't, and I got through fine. You might get the odd examiner that will ask, but it's not like they're going to take off a mark because you don't know. They might add a mark if you know and are able to explain really thoroughly. But it's not particularly high yield, and it's only a might ask you. So not worth obsessing over. If you've got some free time, look into it because it's interesting. Don't look into it because you think you need it to pass the OSCEs. So I always look at the hands first and then palpate. So you palpate the cap prefill, you palpate the pulses on both sides to see if there's radio-radial delay. If there was radio-radial delay, what would that mean? Yep, subclavian stenosis. Yeah? Oh. Sorry. Or it could be aortic dissection, but you'd notice some other signs like them being in incredible pain and not being able to breathe very well. And then pulse, there's a big controversy about whether you should have your own watch and you should take the pulse for 15 seconds or 30 seconds, or if you should ask the examiner. I'm really bad at times tables, and I don't know my 4 times tables that well. So I always ask the examiner, and it was never a problem, and it saved me so much time. So do whatever you feel comfortable with. Practice both ways, just in case you say, can I please have the pulse, blood pressure, and respiratory rate? And they say, oh, the blood pressure is this, the respiratory rate's this, take the pulse yourself. And then just do it for 30 seconds. It's uncommon, it happens. 30 seconds is much better than 15 seconds because if there is an abnormality, you might not notice it in 15 seconds. But if you are conscious of time, if your history's gone over time and you need to shorten it, you can do it for 15 seconds. Peripheral signs on the face, conjunctival pallor, xanthelasma, malar flush, central cyanosis, dentition. That's a few easy ones. You don't need to know all of them. If you do know all of them, it's good. But if you can just say there's no xanthelasma, there's no central cyanosis, and dentition is good, they're probably going to be happy with that as well. But you can look at tallies and see a million different signs. There's probably like 7 for the eyes, and you could come up with 5 for the face and like another 5 for the mouth. You don't need to know that many as long as you have 3 or 4 that you're comfortable with. And know roughly what the pathophysiology is and what they mean. And then position and exposure. So after you've done the arms and face, then I would move them to take their shirt off. It's also really hard when they're laying at 45 degrees on the bed and you're trying to like get up over them to look at their eyes. It's really, really awkward, especially if you're short. So if you do it while they're sitting on the edge of the bed, do their hands and their arms and their face, and then get them to sit down in position to do their neck. JVP, you've all been taught it in clinical skills. Everyone obsesses over it. You can't see it on like 50% of people, so don't panic if you can't find it. The carotids, you'll feel and you'll listen to. Deviated trachea, you don't need to know. I just do it because I like things to be grouped by 3s. Precordium, so you inspect. I've got visible pulsations and dilated veins on there. That's nice. It's uncommon. Why might you get dilated veins? Yeah, in short. Like if you said that to an examiner, they'd be like, yeah, that's fair, that's true. So, I mean, theoretically, coronary artery disease backs up, you get venous congestion. You could explain pathophysiology in detail, but if you say it in one word, they're going to be like, oh yeah, you kind of know what you're talking about. At phase 1, that's pretty impressive. You're only expected to recognize normal. You're not expected to know abnormal. It's a bonus if you do. But if you say scars and chest wall deformities, that's enough to get you through. If you know what specific scars you're looking for, that's nice. It's not necessary.
Okay, I have a quick question.
Yes.
So, obviously we're in phase 1, but I always hear that, we get assessed by, registrars who have wildly unfair expectations of phase 1 OSCE students. What's the deal with that?
If that
They're
happens...
not really sure of the marking criteria, so they just, mark very harshly.
Yeah, so 2 years ago they implemented a new thing where they have made introductory videos for markers. So markers know exactly what they're supposed to be doing because they have these videos. I was never marked by a single junior doctor. It was all consultants, and they were mostly really old, so they've been doing it forever. If you do believe that you've been marked unfairly, bring it up in the information session right afterwards, and everyone needs to bring it up. So if there's one marker that's treated you unfairly, chances are they've treated 5 other people unfairly, but if no one speaks up, then the faculty don't know about it. As soon as you come out of your exam, message your year ups and let them know. And well, no, if you think that they've been questioning you about things that you don't need to know about. So if you think that a mark has been particularly harsh, if they've asked you to do a thyroid exam that you haven't learnt yet, or if they've asked you some ridiculous questions and been like obviously disappointed you didn't know the answer, bring it up. So we'll post that on the year page as well beforehand. And then auscultate. So there's rumours that you need to know the abnormalities in phase 1. It's nice if you know them, but they didn't even expect me to know them in 3rd year. So I don't think it's 100% necessary, and don't stress about it if you don't know it. Just know where the areas are that you need to auscultate, know roughly what normal sounds like, and if you can identify that it is abnormal, that's impressive. You don't need to identify specifically what abnormality it is. And then dynamic maneuvers. So why do we move to the left lateral position? Yeah? Yeah, gravity. And then if you notice that there was an abnormality and it was radiating towards the axilla, what would you expect? So if you're listening here, you're listening to the apex, which is where the mitral valve radiates to. And then if you get them to lie on the left side and it's radiating down there even further, if it moves, you might be expecting that the heart is larger. There might be some cardiomegaly. Most commonly, I believe it's mitral valve regurgitation. That's why you do it. You don't really need to know why you do it. You just need to know that you do it, but that's a fun little fact that will get you a bonus point. And it makes sense, right? Like mitral regurg, if you're hearing an abnormality here and it's radiating there, it's the main thing that you're going to be able to hear. If you're upright and leaning forward, as I said before, if you notice an abnormality in the aortic or pulmonary areas, you might notice it radiating up to the neck. They don't explain it to you in phase 1, so they don't expect you to know it in phase 1. Conclude. So offer to help the patient sit up and get dressed. The examiner will be really impressed by that. That goes into your patient report, which is worth a lot more than your examination itself. And always pause before you begin summarizing. So that's a trap that most people fall into, is that they know that they're on a clock, they only have a certain amount of time, and as soon as they finish the summary, they go straight into the examination, they go straight into the summary with the examiner. Take at least 3 seconds to breathe, collect yourself. Even if you're not thinking through it in your head, just like take a second to breathe. That was the thing that the registrars did really well, and that first years do really poorly. Summarizing. Keep it short and relevant. The best activity that I ever had in summarizing was going to fracture clinic in orthopedics, and they would give me an x-ray and say, summarize this. And I would spend like 3 minutes going through every single detail of like, this is normal, and this is normal, and this is normal, and this is normal. And there's no abnormalities here, and this is the patient's name and age, and this is the side of the body. And okay, do it again. And I'd do it again in about half the time. They go, do it again. And I'd do it again. And after the 4th time, they'd be like, okay, that is how you're supposed to report an x-ray. And then they'd give me another x-ray and they'd say, okay, summarize this one. And this time it only took me 2 or 3 times to get it right. And then again and again and again. And after probably like 5, 6 x-rays, I finally could do it pretty decently on the first time. And then I went into fracture clinic the next week and I sucked again. So keep practicing. Do the same summary over and over until you get it perfectly. So don't do a summary and go, oh, that was shit, I'll do it better next time. Keep doing the same one until you get it perfectly, because the only way you're going to be able to recognize what feels right and what is right is when you do it yourself. Not when you observe someone else do it and go, okay, I'll do it differently. Or I'll do it the same as that. So yeah, as I said, write down your patient's name and age at the start. Start with salient findings. Mention relevant negatives. Don't list every single negative. And you can make a recommendation prediction request for bonus points, but you absolutely don't have to. It's good to have 1 or 2 things in your head for each exam, but again, it's good to. It's not going to lose you points if you don't have it there. And as I said, practice, 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 practice. So an example. Jennifer is a 56-year-old female who presents with a history of crushing central chest pain radiating to the left arm and jaw. This is on a background of hypertension, hyperlipidemia, and diabetes mellitus, all of which are medicated, and a family history of coronary artery disease. On examination, Jennifer had no abnormalities. However, I would like for completion to get an ECG, a chest x-ray, and troponins. That's it. Keep it short and sweet. It doesn't matter that she didn't have any heart murmurs, she didn't have any splinter hemorrhages, she didn't have any cap refill issues. She wasn't on this medication. Like, you just say what is relevant, and I'll be more impressed if you keep that short than if you list all of the different things. The other reason that people tend to let their summaries go on and on and on is if you haven't been allowed to report back as you go, and you really want to show that you were looking for all these peripheral stigmata and that you remembered 20 different peripheral stigmata, that's less impressive than if you're able to do a really concise summary. There was also an idea when I was in second year that you had to write an example summary for every single station and you had to memorize them. The only two people I've heard of that have ever done that are Beryl and Hiram, who are two of like the most high achieving people I've ever met in my life. And if I tried to do it, it would make me fail even harder. Like, I think just have a general approach, keep yourself calm, and you will do it well. You can try the memorization thing if you think it'll work for you, but on the day, I think it's probably going to make things more stressful if you're trying to remember the exact wording of every single one of those 11 summaries that you wrote, other than being able to approach any summary in a standardized and competent way. That's it. Any questions? How much time do we have left? Since we have 10 minutes, do you guys want to pair up and take a psychosocial history off one another? The answer is yes. Why are you sick?
Why do you think I'm sick?
Is there anyone that doesn't have a pair?
Yeah, I left on Saturday. Do you have a So living just with you, any support? We can discuss it. I did ask about sexuality because there's no place.